for all they're worth. You know, you get much more grant money if you have bells and whistles, and one of the bells and whistles are genes, and the other one is imaging the brain. So it doesn't tell us a great deal, but we do know that in fact children who we do know that there are brain differences in this parietal region, the temporal parietal region, which is associated with self-reflection. There are brain region and maturational differences in children with autism versus children who are typically developing. Much more work needs to be done. We are looking at one other feature that is very much related to the emergence of emotion, which is recognizing facial behavior. And what we find there, again, is this deficit in children on the ASD spectrum. We also find differences that are culturally related. Indeed, in an environment which is stressful, now we talk about stress in terms of poverty, but because we don't want to hear about environmental stress in terms of being poor, in terms of poverty. But if you speak to people of what they feel like of being poor, as you know, our politicians, for the most part, certainly those who do not have a progressive agenda, blame poverty on the poor people. That is a perfect setup to make you ashamed. And in the book on shame that I've written probably a decade ago now, the fact of the matter is we have quotes from people who talk about the shame of being poor, the shame. So we have very little research on emotional deprivation as underlying our notions of environmental stress. So if we work on environments with, Erica was telling me of her interest with newly arrived people to our shore and the kinds of needs they have. No one is addressing how shamed they may feel about their difference. So the pitch I would make to conclude is that we're beginning to know a great deal more about the sequence of emotional life. And we do know that one of the central points in its development and in its usage is, in fact, in self-reflection and what comes with self-reflection. One of the most important features is having the perspective of others. Now, Piaget informed us with the task he did that children can do this at about 6 years of age. But we know the theory of mind data suggests that there's a shift down at 3 or 4 years, and there are even studies to show a shift earlier. The fact of the matter, the failure of having perspective, to take the perspective of others, allows us to do many, many things that get us into trouble. One of the classical symptoms both in population work that we do, as well as actually children with Asperger, is in fact their failure to take the perspective of another. Again, this is the use of a self once it emerges. There are individual differences. There are individual differences in this room. There are individuals, as I look in the room and watch, who are not taking a perspective of what is it that the speaker looking at them can imagine they are doing as he's speaking. Okay? It turns out that techies, what we call this general group of people, have a high incidence of Asperger and a high incidence, not that they can't do a theory of mind task, but they don't utilize it. They do not utilize the self in relation to the other. which seriously hampers their social relationships. Here is a smattering of some of the work that we do. It is large and varied, and there are many, many more studies. We are interested in intersensory integration. So when I am speaking to you, my lips, the sounds that are coming out match my lip movement. And we know that if we see a dubbed film and the sounds coming out are not in synchrony with the lip movement, we detect it immediately. Well, it turns out children have to learn through experience. And one of the studies we are doing is intersensory integration. And what we're finding is that kids at risk for autism, I'm talking about 4 to 2-year-olds at risk for autism, because there's no diagnostic, these are the children who need a great discrepancy temporally between lip movement and sounds. Another area that we're working in, we have children in our clinic in a cochlear implant. They're born deaf, and they don't implant hearing devices until they're a year of age. So they're starting off, they can't integrate sounds with lip movements because they don't have any sounds. So now you give them that capacity. How long does it take for them to be able to detect it? You and I can detect if it's off by 100 milliseconds. That's 1/10 of a second. We can detect that they're not simultaneous. When do children in their development learn to integrate? There's another area of study going on. We are interested in looking at shame and pathology. What kinds of symptoms do high shame people show from a psychological, clinical psychological perspective? What's the relationship between shame and disgust? Because disgust has been implicated in terms of phobias. So these are just some of the work. You can go on our web page and find out much more that we do. But I thought what I would do here is to sort of give you a broad overview of what the first 3 years of emotional development is like, where some of the atypical fit in, and extend this work into looking at populations that show deviation from the norm. So I thank you for your attention.
We'll take questions for Dr. Lewis. That was fascinating.
Your use of the Genesis story, and I think if I understand the diagram you put up a few times, suggests that there's sort of one change that leads to this reflexive consciousness, not a bunch of small pieces. Is that what you're saying?
You know, the problem in all developmental studies, and it's a problem in all measurement, is if you repeatedly do it, the sense is that you could get smaller units of time. Our work, longitudinal work, is in general finds that there is, once they get it, they've got it. They don't have it at 15 months, let's say, early, only 15%, and then lose it and then re-get it at 21. But that's a very interesting developmental question, which of course is no longer asked, but it was truly asked many years ago. Namely, and this is important for education, the onset of a skill and the ability to use it at all times. Walking is one of the areas where the original work was done. You can measure the first time they take a step without holding on, or you can measure when they walk without support. They are not the same measurement. So someone can actually do a skill earlier, but not utilize it as fast as someone who's delayed in doing it and then utilizes it. It's a developmental question that was asked 50 years ago, and it's no longer asked. It's always assumed, even in longitudinal research. If you've done it, you will do it from then on. In terms of, we don't do it by the day, so I really can't tell you, is it a turn on, turn off switch?
Not quite that. So
Oh,
is it
sorry.
like you get self-awareness, and then you understand that other people have states, and then you get that those people have, is that one skill, or is that a bunch of separate maturation?
It is clear that self-recognition, that is, I know, is earlier than the recursive. I know, you know, you know. And that takes later. So we know the self-conscious emotion, shame, pride, guilt, evaluative embarrassment, don't emerge until 2.5 years of age. Whereas empathy, or the failures in empathy, emerge much earlier. That is, emerge at the same time that self-recognition emerges. So there is a sequence. Clearly, it doesn't all just pop out. Because for self-conscious emotions, you must have values and standards and goals. Where do they come from? That's what's taught. Okay? So, no one in this room would this be true, but there are some students who, if they get a C, are perfectly happy. There are students who get a B plus and are miserable because they haven't had the standard. That's taught. I tell the story, I've always told it about a patient. I'm a trained clinical psychologist, but it's really about me. I came home in high school, I took a chemistry course, and I got a 97. And my father said to me, Michael, what happened to the 3 points? You end up with someone with a high achievement need. So values, goals, and standards are taught. That's the massive cultural contribution. You don't learn to be ashamed. Shame itself is part of the mechanism of humanness. You learn how to express it or not. You learn what conditions are likely to produce it or not. But the actual feeling, shame, I want to die, hide, and disappear, I feel terrible about myself, that's not learned. Okay? So the culture, if in fact is, I have to talk to geneticists, the culture gives expression to the genotype. The genotype is human beings can feel this. We can feel all these emotions in all cultures, probably in all times. Do we express it the same? No. In the same way that when we go in some cultures to a funeral, people are wearing white, and in other cultures they're wearing black. We know that sadness is a general, should be expressing. You shouldn't be laughing out loud, you shouldn't be doing all sorts of things. Across cultures, we know that. But we know other things are very culturally specific, and indeed familial. So what constitutes standards, rules, and goals of the child are really the education of the organism.
Oh, go ahead, Daka.
Your explanation about the emotions makes me recall an experiment by Watson. Watson, like white rat and the fear. Like the fear, that experiment tells us like the feeling of fear can be taught.
No, not the fear can be taught. You can associate.
Okay. But you don't
one
think that's...
stimulus. What Watson's experiment was, which by the way has been highly criticized on moral grounds, and it's a very interesting story which we don't have the time. But what he did was he subjected the child to shock in the presence of so the child, if any stimulus, if you associated a blinking light with a shock, you'd come to associate that blinking light with something that's going to hurt you, and you would show fear or anxiety and so on. So, but the fear and anxiety isn't taught. The emotion isn't taught. No one taught you shame. They taught you what to be ashamed about. No one taught you pride. They taught you what to be proud about. These emotions exist. Now, I have to say there are people who truly believe that they are universal, that these are part, if you like, the part of the human experience. And lots of cross-cultural studies tend to support that. There are others who believe, much as you've stated, that in fact emotions are taught. Emotions are nothing but cognitions. So there are schools of thought who hold that. But it's never very explanatory, because what they can explain is what you learn about how to express it or not, and what events cause that. They never talk about the fundamental feeling of it. So, yeah.
Is there another question? I'm going to ask. Do you mind? Do you want to go or? Oh, okay. So I have a million questions. I'm going to ask one though. What do you think about the interaction between some of the phenomena you're talking about in the Big Five personality theory?
Well,
like conscientiousness and getting a bad grade. You know, a C, if you're
sure.
not that conscientious, you go, way, I got a C, right?
You know, if I could think of a good name for something, I'd call it the Big Five, or an attachment, A, B, C, and D. It's very nice when you have a very simple classification. I have some real questions about personality. That is, underlying personality is what? Is that you will behave, think, or feel the same way across multiple situations and across time. The basic idea of personality is something in us that we carry. There are other people, and indeed there is not strong literature on that, and certainly not in terms of early. The question of these personality characteristics, or the configuration that make up the personality of the person, with these different features of it, different dimensions. We've been doing dimensions of personality. We can go back to the beginning of psychology and find, I'm blocking on his name at the moment, but there's a whole book listing all the different features of personality. So how do they fit? There are people who use the Big Five. They use it as a phenotype when they're looking for genetics or when they're doing brain. But all we fact behave the same way across situations? What you see of me, is this the same thing that you would see in a party? If we were all drinking and socializing, and am I the same in the same way? Well, clearly, most of the time I don't even wear a jacket. Okay? When I'm in my lab, when I go to meetings, I don't wear a tie, I don't wear a jacket. But I do wear a tie and a jacket at certain times that are more appropriate. So I put a jacket on over my t-shirt whenever I'm going to give a lecture, because of a man of 80, appearing before people and telling them what they think, I do a better job of it if I look more professorial, more professional. So so what would we say is my personality? That I dress variable. If I go to talk to pediatricians, I wear a funny tie, because pediatricians wear. I wear a shirt. I wear often a suit. Pediatricians wear suits. If I go to a psychiatrist, I wear gray pants, a tweed jacket, and I can wear a turtleneck. If I go in arts and science, I can go any which way. So many of us learn rules and we vary our behavior by situation. So I'm not at all sure, and it worries me because I'm interested in developmental psychopathology. Well, I'll tell you very simply. Who determines if you have pathology? If you're the audience age, you go to some health expert and you say there's something wrong with me, I'm depressed, I'm anxious, whatever it might be, okay? If you were 10 years old You can't go to a mental health specialist. Your mother reports what's wrong with you. So who is the reporter turns out to make a difference. There are any number of studies. There's a study I did many years ago with a graduate student that is often quoted. We have the mother rating the child on depression. We have the father rating the child. We have the teacher rating the child. And we have the child rating the child. We had 150 kids in the study, and there was only 2 kids that everyone agreed. All the others, one or another of the people, and there were very few in which 3 out of the 4 agreed. So we talk about pathology. Mom takes the child up to what age? The mother is the reporter of the child's pathology. Child can't go and see, can't go to the school system and say to the teacher. Teachers see the child in a particular situation. Okay? Their evaluation of the child's being depressed is the child's sociability. They know nothing about the child's eating behavior. They know nothing about the child's sleeping behavior. Mom, who knows more about that, utilizes these to talk. She doesn't know anything about peer relations. So she's reporting. Dad doesn't know anything about anything. So if he's depressed, he reports the child is depressed. So who is the reporter of, quote, the personality of the child? Depends upon situations in which the child is seen. So one of the problems in developmental psychopathology is, in fact, what's going to be the criteria that child is, in fact, depressed. Out of 150 kids in a longitudinal study studying this, we had only 2 kids where the 4 people agreed that the child was depressed. So who do we take? When the child, we take mother's report. And now we have this problem in high school. You can go speak to your guidance counselor, the nurse, but she's going to say, or he's going to say, hey, we got to get your parent in. Parent says, no, I don't think my kid's depressed. Nothing is going to happen. However, you get to college, now you can say that you're depressed, and the therapeutic agent doesn't call up and say, wait a minute, you say you're depressed, I want to call up your mother and find out if you're depressed. So who the report is turns out to be related to situations in which you behave, and there's not general agreement. It's one of the real problems in developmental psychopathology, and who's reporting on who's depressed or not.
Do you want to ask your question, or should we end?
Very similar to that.
Oh,
I
I
was
see.
just wondering if, with measurement given to pediatricians, and they tell the parents, okay, that they didn't pass the test. They didn't pass
A little
the
loud,
test.
I don't think anyone can hear you.
Okay. I was going to ask about what comes after, giving pediatricians this sort of standard measurement.
Well, the problem with the pediatrician is they don't know enough. And the average time a pediatrician comes in contact with a child and the mother is about 7 minutes. Total time she spends now, more she's than he's in pediatrics. They need to see 60 patients a day to earn a living, what they consider a living. So the medical school, all pediatricians in a tertiary care center will have to see very many patients. So it's very hard, unless the mom describes the problem for the pediatrician, which requires her to be educated and essentially to be educated. Pediatrician's not going to find it readily in the exam. So one of the things we try to do, and I should mention this, we have a practicum program. We now have social workers and psychologists, and I would love to see people interested in education join this practicum, you can get credit for, program where we immerse you into either outpatient clinic or patients in the hospital, inpatient, and patients and family, because what we need are people who have knowledge about children, about education, about intervention, about personality, who have educational interest, we need to embed them in a pediatric setting because the pediatricians are simply not trained. For the first time in the last 10 years, 50 years before, there wasn't a single question on their boards to get licensed that asked about development. So when I see a young pediatrician and I say, hey, I have a 5-year-old boy and he pees in bed twice a week. Is that normal or is that pathology? Because if you think 35% of boys do this, which indeed it seems to be the figure, that's not pathology because 35% of men don't end up being in bed at night. It's a developmental, they're taking longer to be trained. If, however, you think that it's only 1%, now you call it enuresis, and now you're going to start treating as pathology. So without knowing the developmental sequences, without knowing something about what is the process, in this case, learning, to use the bathroom, you get stymied. You get into a lot of trouble. It's very difficult to change pediatric. This nose test takes 15 seconds. Any child 2 years of age. I'll give you a second hint. If you ask the mother, does the child give me the vocabulary, number of words? If the mother can't mention more than 30 words that a 2-year-old, the child has, or has no 2-word utterances, which are 2 nouns usually, mother, mommy, shoe, and holding the shoe in the hand, meaning, mommy, my shoe came off. 2-word utterances and 30 words at 2 years of age. If they don't have it, you want to refer that out. If they don't touch the nose, you want to refer that out. It takes no time. Yet they continue to look down their throat, listen to their heart, listen to breathing, coughing, and doing simple reflexes as the major part of their examination. So, which I'm going to tell them nothing unless there's a serious problem.
The last question,
Sure.
Carrie?
Thank you for your presentation. How do you understand the relationship? Is there a relationship between some of what you've been sharing today about the sort of the ability to recognize and the incredible explosion in diagnoses of children
Of
on the
autism,
autism and
yeah,
Asperger's
well.
because I feel some concern with that. That seems to be a sociological phenomenon.
Yeah,
You're
you're
talking
absolutely
about
right.
this as a biological phenomenon.
You're absolutely right. I believe, they estimate 1 in 68 kids in New Jersey on the spectrum. It's not true. First of all, they've changed the criteria. So there were lots of kids who behaved strangely. They had no categories for them.
Many of them are in this room.
They throw them in. They've thrown them into autism. Everyone knows that there are services because the families of autistic children with autism, have made political treatment. So there's lots of money. So my granddaughter, living in New York, diagnosed, well, we diagnosed her about under a year, but her pediatrician diagnosed her about 14 months. As soon as she diagnosed, the child was eligible for services. So, hey, you got a place where you can send this kid, and the parents will get some services, so it's increasing. If in fact you look, and the other thing is, as soon as you put a lot of emphasis on a diagnosis, you increase the likelihood of seeing it. So I remember going to my physician. I had some stomach pains. This was quite a few years ago, and I had been to Japan lecturing, and he read in the New York Times that there were some stomach things with eating raw fish, and so the first thing his diagnosis was, well, it must be from the raw fish. Of course it wasn't, but the point is that a good deal of the evidence can't be coming from careful study. That's not to say there isn't progress in medicine. There certainly is. But it's very specific, highly specific and related to hospital kinds of problems. Our problems in learning disabilities, our problems in emotional, our problems of abuse, all of these, the percentage of children is very, very high. All cancers are 1.5% of the population. Learning disabilities, you're probably up to 10 to 12%. So where you're going to put your money, where you're going to put your effort. Third-party payers don't pay. So poverty kids go into special classes as opposed to be given a more. So we're not focused on it, but that's, you can see it in the political parties we have today.
So I think we should probably end, although I bet you all of us could sit here for a long time and ask you lots of questions. That was really fascinating. So please join me in thanking Dr. Lewis.
Oh, so none of you asked what tooth. What's the secret? There's usually someone in the audience who remembered my saying, what tooth do you think was her favorite tooth? It's the canine. Canine was her favorite tooth. So that's the end of that.
Well, there's variants on canines because Slav and people like Slovenians, Czechoslovakians, they have flat